All right, so welcome back. In our last session, our almost last session, we'll be ending today with C.N. Robinson. We're going to talk now about improving population health during and after a pandemic. And this will be the first time I've done something that's all virtual. We'll be having our guest panelist virtual, so you'll be experiencing this with us. Our first guest is Dr. Sandra Brown. She serves as Dean of the College of Nursing and Allied Health at Southern University in Baton Rouge. She also chairs Governor John Bel Edwards' COVID-19 Health Equity Task Force. Dr. Brown has more than 31 years of experience in the field of nursing, having earned a doctoral degree in nursing science from LSU Medical Center. And I do want to say as an aside that Southern School of Nursing was created in 1985, and it's one of the top producers of undergraduate baccalaureate degrees awarded in nursing to African Americans in the U.S., which we should all be proud of. Dr. Sandra Brown, welcome to our panel.
Thank you. Hello. Can you all see me?
Yes. Good morning.
Hello, everyone. It's a pleasure to be here, and I'm grateful to be here with the panelists. Do you want me to get started with the slide presentation?
Please. Yes.
Okay. All this technology.
I know.
It was just up there a minute ago.
There we go.
Can you all see this? Yes. Okay, great.
There you go.
I thought a fitting title for this presentation would be COVID-19 and Health Disparities, a Crisis Within a Crisis, because that is exactly what we are experiencing. I'd like to start with our Louisiana health rankings. Louisiana, unfortunately, ranks 49th in the nation as one of the least healthiest states. We also have very poor rankings as it relates to our prevalence of diabetes and cardiovascular disease and obesity. And we're the third highest state in the nation for our poverty rate. We have held this ranking for some time now. This is nothing new. We flip-flop with our neighboring state, Mississippi. One year they're 49th or 50th, and then one year Louisiana is. So these rankings we've held for decades. When we talk about health disparities in Louisiana, when you look at the chronic illnesses I just mentioned, and add that to low socioeconomic status and barriers to accessing quality health care, it's going to yield poor health outcomes and perpetuate health inequities. So when we talk about health disparities in Louisiana, this is the very simple formula that we're faced with. We cannot talk about health disparities without looking at health equity versus health inequity. So health equity means that everyone has the same opportunity to attain their highest level of health, whereas health inequity, it stems from generations of African Americans who've not had access to resources to obtain that same level of quality health care. So how has COVID-19 impacted Louisiana? What it has done, it has put racial health disparities and economic inequities in the spotlight, of which Louisiana can no longer ignore. We applaud Governor John Bel Edwards for appointing the Louisiana COVID-19 Health Equity Task Force. He heard our voices and he took action, because early in April, we were facing a huge disproportionate allocation of the COVID-19 impact on African Americans. So he appointed a COVID-19 Health Equity Task Force. I serve as co-chair of it, and my partnering co-chair is Dr. Thomas Levis, who is the dean of the School of Public Health at Tulane. The COVID-19 Health Equity Task Force is comprised of over 50 members of subject matter experts from across the state of Louisiana. And so our charge was very simple. It was to provide recommendations relative to health inequities. We were to provide reliable data as it relates to COVID-19, and we were to develop a statewide dashboard on health equity. We look at this as an opportunity to not only address COVID-19, but to take a deeper dive into real-time interventions that we could use and take real action. And so the task force came up with 9 priority areas. Our first priority area, of course, had to relate with testing for vulnerable and at-risk populations. We wanted to ensure that anyone and everyone who wanted to be tested could be, and that there would be no charge. And we encouraged the removal of those barriers, and that those testing strategies would be strategically located in communities where vulnerable populations were most impacted. And we also emphasized adding testing strategies for our frontline workers. Communications and messaging, this is a subcommittee that's looking at getting our message out. We know that the messenger is just as important as the message, and the messenger has to be relatable, reliable, and trustworthy, because public health is built on public trust. And so we're using some strategies, all the social media platforms and billboards, digital billboards, to get our messaging out about proper wearing of the mask, about myths as it relates to COVID-19. Our data and analysis subcommittee has looked at data that has been provided to us by LDH. One of the things that we noticed early on, that there were gaps in the data. We wanted to receive data based on zip codes, because we know that a person's zip code is more important than their genetic code, because where you live should not determine whether you live. And if we could take a deeper dive into where the zip codes were most vulnerable, then we could target some populations that we could reach. We also wanted to ensure that the data was accurate, because accurate data gives us an opportunity whether to loosen up or open up restrictions, and faulty data is worse than no data at all. The Health Equity Dashboard, this committee recommended key elements that were going to go into the dashboard, looking at social determinants of health. We're going to house that Health Equity Dashboard at LDH Equity website. It's being built. We're looking at social determinants of health and political determinants of health. We've also looked at other states and what they're doing, how their health equity dashboards are devised, and learning best practices, and still holding on to the nuances that makes Louisiana so unique. So this health equity dashboard, we're hoping that it will be engaging and that it'll be real time and accessible anytime, anywhere, using mobile devices. We also thought it was important to look at special populations. Louisiana prisons was one of our populations. We wanted to make sure that the state was doing what they were obliged to do, and that CDC regulations were being adhered to in that population. Nursing homes was another area that we looked at as far as vulnerable populations. Early on, we realized that over 40% of the deaths that occur in the state of Louisiana have occurred in nursing homes. So we wanted to make sure that a strategic, comprehensive plan was in place to protect the residents of the nursing homes. Policy and Regulatory Affairs Committee, this is the committee that is going to recommend to state legislature different aspects as it relates to access of care, discrimination. We know that the country is facing 3 epidemics right now. We have a economic pandemic going on, we have a physiologic pandemic, and a sociologic pandemic. And all of those pandemics are coalescing at the same time. The community outreach and stakeholder engagement is looking at grassroots level, identifying platforms that we can increase community engagement as it relates to COVID-19. Who better to tell their story than the individuals who have lived it? And our last priority area is racial disparities in healthcare. That subcommittee is looking at our crisis of care manual That manual is our go-to manual when a crisis occurs in the state. Well, that manual is over 10 years old. So that committee is making updated recommendations. And they're also looking at medical mistrust and biases that occur among our citizens in Louisiana. So those are our priority areas. We've met with other health equity task forces. We're forming coalitions with other health equity task forces throughout the United States. We're not too proud to learn what works for them that we could apply here in Louisiana. When we started this task force, we had no real blueprint, just a group of dedicated individuals who were committed to making meaningful change for our citizens. We know that this is a movement, it's not a moment, and that we've got to use this crisis to make a difference for generations to come. We're not satisfied with being 49th in the nation as the least healthiest state, and we cannot go back to status quo because everything has changed. 2020 is the year that has changed the world. Thank you. You can also access the full recommendations of our 9 priority areas of the Health Equity Task Force by visiting www.sus.edu. That stands for Southern University System. And you can email me directly if you have any further questions. Thank you so much.
Thank you, Dr. Brown. Hold on with us. We're going to have a couple more speakers, and then we'll allow all of you to speak together and maybe share some notes. I'd like to welcome our next guest, Ryan Bosch, Ryan Bosch, founder of Socially Determined, a Washington, D.C.-based technology platform that integrates knowledge of the social determinants of health with clinical data through advanced analytics. Their mission is to better understand the impact of the social determinants of health to thereby improve the health of millions of people. Ryan is a graduate of the University of Virginia School of Medicine. He attended school on a U.S. Air Force scholarship. He earned an MBA in healthcare informatics from George Washington University. Dr. Bosch? He's not here? Okay. Is Dr. Brown? You think Dr. Brown can hear us? Okay. And we are ready? Okay. While we're working on our connection, I'd like to welcome Dr. Iris Malone, a family nurse practitioner with Our Lady of Lourdes. Dr. Malone earned a doctorate in nursing practice from the University of Alabama. She also oversees primary care services to students and faculty at Northside High School Health Center, a school-based health clinic, which is a collaboration between Our Lady of Lourdes and the Lafayette Parish School Board. This center provides free healthcare services to students and staff in the 70501 zip code, an area deemed high risk for health issues. Dr. Malone, are you with us?
Yes.
Yes, good morning.
Good
this
morning,
is Jan.
everyone.
Hi. Good morning. Thank you for joining us.
Sure, you're welcome. So there's always a ram in the bush, right?
Yep.
I come on and save the day. So I am going to speak on my personal experience as a primary care provider and also with working among adolescents and with the school-based health center. I'm going to tag on a little bit to what Dr. Brown had mentioned in her presentation, because there is so much that that's going on for the year of 2020. And as she says, is a movement and not a moment. Mm-hmm. And so I will speak to my experience about that particular concept, because I want to know for sure, is it truly a movement and not a moment? And are we just caught up in the hype of it all? Of course, we have known and health inequity for quite a long time. We talk about the different communities that we serve. We know that that low socioeconomic income families are the ones that suffer the most or have the most health issues. But then I start looking at, and I wonder if some of that is basically true, or is it a cultural thing? I don't know. I've been brainstorming over the last few months. And I look at the fact, and I have a PowerPoint, so my eyes is not going cross. I'm just going back and forth, okay? Because I know I was trying to share it, but if we're not able to share my screen, that's fine. So I just want you to follow along with me. In regards to health insurance, we always say that there's limited access to health insurance or healthcare providers that can care for those most in need. Part of that is true, but in the community that I serve is heavily Medicaid, so they have access or they have the ability to have the insurance, and some of them have access to providers. But what I find is that sometimes we do not understand how to communicate in a culturally sensitive way with our patients. Sometimes they'll leave the provider's office, and I get this a lot in just with my church home, my church members, and the people who we do health fairs and those types of things with. And they will come from the doctor's office, literally sometimes, straight to me and ask me the questions about what they heard from their provider because they didn't understand what was being told to them. And so, sometimes it's a shame for you to have, this insurance and you have your provider explaining things to you, but then at the same time, you're still not understanding and you're missing some of the important piece of how to care for yourself. And so I find that a lot when we talk about health insurance coverage, that with the Affordable Care Act, that we do have people with health insurance. But yet, like I said, that the health providers, I don't find that we're doing a great job of educating our people in a way that they can understand. So guardian and family health literacy is another barrier to care. We have families who will probably learn how to communicate with each other about what they understand. And so they'll explain it to their family member. And I find that especially among certain cultures, African American culture, that we hear what the other person is saying. We hear what our peers and our friends and our neighbors are telling us about what we should do, even though intellectually we learn about certain things. But at the same time, if my neighbor or my friend says, I heard that if you do this or if you take that, that'll work better for you. So I find that it becomes more of a sharing of ideas among a social group. And I'm not sure that's considered illiterate. I just think that we trust what we say among our family and our friends. I had a student one time, and here I'm telling her she needs to increase her water intake. She needs to make sure that she eats healthy. Well, she says, okay, that's fine, because, she's come to me with several times. She's had bladder infections and so on and so forth. So I usually ask them, do you have water? Because we always say drink more bottled water. Well, of course, she didn't have bottled water. So I told her how to be able to take water from the faucet at her home, put a pot on the stove, boil the water, and then now you have good, clean water. So she took my idea and she said, okay, that's fine. Then I said, well, are you drinking more water? Well, no, I'm not drinking more water. Why? She says, well, we don't really have water in the home. She's found out that she has to go underneath her house to be able to turn on the water faucet because the water was turned off. So then I bought her a container where she can boil the water, put the water in a container, and put the water in a refrigerator. It has like a little spout on it. So she took that idea and she says, well, my mother loves it so much that she's using it to wash her hair. So she uses it like a sink, and she puts her head on it and she starts washing her hair with the little water faucet. I'm saying all of that to say, Even though we explain things to our patients, we have to be able to dive a little bit deeper into what they have available to them, and don't assume that they have access to these things because we're living in modern day time. It may not always be that way. So that our home environment plays a big piece into into the barriers to care. Unreliable transportation. We all know that transportation is an issue. Many people ride the bus. They can't have access to getting to the bus on time. I've had students where um, providers, specialty providers, have dropped them from the care. Now, granted, they have limited access, especially to specialists. Well, they dropped them from the care because the patient was unable to get to their office in a timely manner or that they missed appointments. I've had to, on a few occasions, these were students with heart issues who had open heart surgery, who's come to me during school time and saying, I'm having chest pain. Well, as a limited provider in a healthcare setting, I'm not their primary care provider, but then yet I got to do that case management piece to be able to find someone who accepts Medicaid to get that child the care that they need. So transportation becomes more of an issue than just getting on the bus. Providers are dropping them from their care because they're not keeping up with these types of appointments. Make a long story short, I met that same student working in Walmart after she graduated. She told me that she had fainted on the job because she went into atrial fibrillation. She ended up having a pacemaker put in, and that's how she's doing today. But she appreciated the fact that I was able to connect her and get her the care she needs and beg the provider to be able to take another student with limited health care and limited access to specialty care. Prior experience we lack that creates lack of trust in the health care is another barrier. We all know that sometimes we don't trust the primary care providers, either because they're not explaining things correctly to where I can understand, or they're running us out of our office because they have yet to get to the next patient. And I've heard that a lot. I don't understand what so and so is saying, what the doctor is telling me, or I don't understand, they seem like they're not taking their time with me and that they don't care about me anyway. So, I don't really trust what they're telling me. Cultural competency, lack of healthcare provider training. We as providers need to become more culturally sensitive, and I think that that's one of the big issues. You can be an African American physician, but that doesn't, or a healthcare provider, doesn't mean that you still understand how to be able to communicate with your particular patient. And let's go down to this. Excuse me, I'll get to the next slide here. And so, what can we do in regards to health equity? We know that there's longstanding systemic health and social inequities. They have contributed to racial and ethnic minority populations being disproportionately affected by the health issues. We need to be able to hold those candid conversations, as we always say. But sometimes that's getting out of our comfort zone, which I'm beginning to be more comfortable with sharing my experiences as an African American primary care provider. It was kind of difficult at one time because we didn't know for sure how our patients would accept it, how our coworkers and peers would accept our conversations that we have. But we all have these challenges as providers, to be able to understand our patients, to be able to work among our other peers and share those candid conversations to say, really, we need to be able to, and then also too, when it comes down to health disparities, what can we do? Of course, we can work together. I'm a nurse practitioner. I have tried on occasions to be able to communicate with primary care providers. Some of them see it as some type of stealing their patients. But when I find things on patients that these students were not assessed for whatever reason. Many of my students that I see, when I refer them back to their primary care provider, because I found lumps in their brain. I've had some patients to say, some of the students to say, well, my doctor never even touched me. You know, I said they never did a physical examination. Did they listen to you? Had that with the mother or the parent, and they did not. She said, I've never had my child to have an actual physical examination, a comprehensive physical exam. So again, I try, my best to work with other primary care providers to share the types of things that I do with the school-based health center, to be able to say, let's work together and let's share, making sure that that student gets the total type of care. If I find one thing, I will definitely tell you so that you can continue to give that child the care that they need. Some of them accept it in a welcome way, and some of them think that, again, I'm stealing their patients. I think that if, as a community, if we collaborate with doing health fairs and health expos, is all great, but it's the follow-up that's the most important thing. Is the surveys as to say why, when your blood pressure is 200 over 180, you haven't been taking your medications. Are you on medications? Why are you not taking the medications? Many community members, many participants in the health expos and health fairs have said, I'll take my apple cider vinegar, or I'll deal with that when the time comes. Many of them use the emergency rooms as their primary care provider. They have insurance, they have providers, but yet they go to the emergency room because when they feel it, that's when that's when it means more to them. So I think we need to have these conversations with our patients, understand the culture, understand that there's from these health issues to be able to have care providers that look like us, that can communicate, that can relate more to our patients and our students. And that is my part of the conversation.
Thank you, Dr. Iris Malone. And I think now we're ready to queue up, are we right, for Dr. Ryan Bosch. Dr. Bosch, we introduced you a while ago. I thought you were on our Zoom call. Ryan Bosch is founder of Socially Determined. He's out of Washington, D.C., and he's going to share with us their technology that they use to identify these social determinants of health we've been speaking about. So we're really looking forward to hearing your message, Dr. Bosch.
Thank you, Jan and Holly, and hopefully my sound is coming through okay.
I think so. Yep.
Excellent. It's a little bit of a helpless feeling to hear your introduction before, but to not be able to do anything but see it on TV as I was following the live stream. So thank you for your patience now that we've got this technical difficulty fixed here. I wanted to share my screen, if that was all right with the group, for folks in the room to be able to follow the slides. Jan and Holly, are you able to see those?
Yes. Thank you.
Super, super. So again, good morning. Thank you very much for having me. My name is Ryan Bosch. I'm an internal medicine doctor, trained in the military, grew up as a public health officer, and really appreciate the comments in session 1, session 2, and also here by my co-panelists, Dr. Malone and Iris Malone, or Dr. Brown, I'm sorry, excuse me. I wanted to start here with the question that was put forth, and that was, how do we predict high-risk individuals and proactively identify health issues, particularly related to this pandemic that sits before us? In my personal experience as an internal medicine doctor, people look at us, all of us as panelists here, as providers. But I want to ask the group at home and in person there to think about this at scale, to think about this as groups. I will circle back to the individual social needs of a patient, as that affects their clinical outcomes and their utilization. But I want to make sure that as you view my comments in this discussion, before we get into our broader panel discussion, that you think about this at scale, looking at the demand, the common view of risk, to understand what are those social factors that affect the clinical factors, thus affecting outcomes. And those outcomes can vary from cost outcomes, care outcomes, health outcomes, and ultimately outcomes around the community wellness. So first, from a technology standpoint, what I advocate for, and my company has been involved in multiple partnerships around, is establishing a common view of risk. And that goes right back to the fundamentals of knowing your customers, knowing your communities, and then knowing what resources you have, so that at scale you can deliver precise and effective care. So what are the steps for that? What does that really mean? Well, among a pandemic that we have now, I don't need to convince this group. I've learned and listened all morning about the impact that social risk has as a driver for health, for access to care, for the access to clean water, for access to transportation, for health literacy around what conditions need care and what conditions might be able to be set aside for a period of time during the pandemic. And then also I want to recognize the underpinnings of the pandemic clearly affects certain comorbidities, the tendency for a touch of sugar, as some of my patients would call it, to have diabetes or the sugar or pre-diabetes. These conditions, also asthma and heart failure, significantly contribute towards risk of COVID. So if we're going to improve outcomes and match resource allocations at scale, we need a way to do this. So we've established and seen through different work with our partners is establishing different social determinants of health risk levels. So levels within the community, levels at the individual longitudinal sense, and then levels around social needs. And I think Iris was mentioning that directly, and the social needs are of a person. So that's an attribute of a person. So staying at the highest level, the community level, COVID-19 Social Susceptibility Index pulls in factors around age distribution in a community, understanding the community's risk for disease burden, common crowding and housing situations, economic stress and access, the infrastructure within the community all affects the ability to seek care, be cared for, and the risk susceptibility to COVID. And we can know that in a proactive way. And we can do that at the state level. Some of our partners in both Maryland and Ohio are doing that right now. The middle area on this slide is looking at that longitudinal risk. So the risk for a risk factor, like we think about clinically for heart disease, a risk factor may be high blood pressure or gender. This is COVID longitudinal risk at the individual level, understanding that person's disease burden, understanding their specific exposure to social determinant risk, their housing situation, their health literacy situation, their social isolation. Many of these comments were already raised and discussed today. So after we have that type of risk view, a common view of risk, then we have an opportunity to look at our population. And I ask the audience to think about the population as anyone you serve. It could be citizens in a state. It could be beneficiaries on an insurance plan. It could be patients within a hospital. It could be an employee situation. So the risk factors help you identify the vulnerable populations. And that's so important as we think about not just COVID susceptibility, but recovery and understanding how the underlying clinical conditions, both social and clinical, play a role in recovery and those primary outcomes. And so those primary outcomes have been talked about in some of the earlier sessions today, but clearly those primary outcomes have to do with health. Notice I didn't say health care, I said health, making sure that vulnerable populations that are impacted by the pandemic, not just by being afflicted with the condition or the sequela of the condition of coronavirus, but are afflicted by the changes in their economic position, the changes in their current healthcare plan, and the changes in their access to care within their areas. And some of that was even discussed earlier by Dr. Logue in the first session, just talking about how the hurricanes have changed access during this pandemic there in Louisiana. The slide I'm showing now, and I wanted to make sure to go through this rather quickly to take questions and be interactive on the panel. It really takes home that opportunity for a common view of risk, to understand geographically where the customers are, to understand where that population is most at risk at scale, and then to understand how that you can drill in specifically on those needs and be able to figure out which parish, which population might have concurrent risk of social isolation and health literacy on top of a reduction in access, or which population may have risks around cultural competence or ethnicity given COVID, or even the underlying risk factors of COVID, like diabetes and heart disease, and really being precise with your programs. We know in Louisiana alone, through our association with Lafayette General, with Beacon, with Holly, with C.N. Robinson and others, that there's many programs that are geared up, and they fall in the supply side, the resources. And these programs are directed towards health literacy. They're directed towards housing. They're directed towards improving social isolation, improving access to care. But where are they best targeted to support that focal population? That's what you get when you have a common view of risk. Let me give just a few examples in one more slide. This is in a state we work with, and in that example, we were able to work as a partner directly with the state. The state developed a task force for vulnerable patients. It's about 3 months ago when this began, well, 4 months ago now. And that task force started with all 6 million members, citizens, if you will, of that state, and then looked at everyone on that state that was in the line of business of Medicare or Medicaid specifically. This state is on one of those waivers, so they have total access to all the utilization claims. By looking at individual and community risk, we discerned down and distilled down to 900,000 folks with elevated individual risk, and then re-stratified to 150,000 individuals with the most risk. And then through that targeting and that support, we were able to turn that information over to the Health Information Exchange, which drove that information directly into their PACE program, their municipal programs around protecting the elderly, and their age programs. So it allowed folks to be supported in place in some of the homeless shelters. But it also put that information right back to the doctors, the providers, the nurse practitioners, the other team members that work and can see their panel and understand whom in their panel has the most risk for COVID. And it's allowed them to be much more focused in their actions. Last slide in here is just a few examples that I wanted to throw out there as best practices that we've seen and our partners have used. I've hit on some of these already. These examples down below have to do with understanding where your homeless populations are, where the folks have the greatest risk for housing instability. That social risk doesn't usually run in isolation. There's concurrent risks, both medical concurrent risks and risks of transportation. And so knowing how that risk profile sets up can help support the program that then is matched from a resource standpoint to those needs. The two other examples here have to do with an elderly program, another group that's at high risk to COVID, and then also uninsured, understanding that in the situation, as I mentioned, we all have seen the ramifications of the economic downturn and the impact that that has had on jobs and having access to healthcare. And we know that Medicaid as a line of business will go up in its enrollment. My last example before coming to a conclusion is right there in New Orleans. I want you to know that we are partnering with a large national payer on one of their Medicaid plans to specifically provide individual risks around the social determinants of health, housing, food, transportation, health literacy, economic well-being, and develop targeted subpopulations where the resources that are being delivered through community benefit dollars and others, can really focus and lift up those team members within the parishes that need it most. So in summary, I'm honored to be able to share some of this work with you guys and gals. I'm humbled that this isn't this time period. What we've learned, though, is that to address risk at scale around COVID, not just one doctor and one patient, we need to look at the whole picture of the patient, the 360 degrees, if you will. I learned that from my early days as an Air Force physician, where I grew up under the patient-centered medical home. So treating that whole patient, their social needs, their clinical needs. So knowing that patient and knowing the community matter. And I think this is what we all want as we try to think about ways we can control to the best of our ability the risk of COVID to vulnerable populations. Janet and Holly, I'll pause there and answer any questions or support the panel.
Thank you, Dr. Bosch. You know, I think the timing worked out well, having Dr. Brown and Dr. Malone speak before Dr. Bosch. You've each built upon the message, but what I've heard was that people first need to trust the messenger when they're getting advice on health care, whether it's from a friend or a healthcare provider. So first they have to trust the messenger, and then they have to understand the message. And I'm kind of curious, if I may ask Dr. Brown, are you still with us on the line? Oh, everybody's on it. Dr. Brown, teaching
Yes.
the nursing students, is this part of the curriculum? How do you educate your young healthcare providers to understand the underlying importance of delivering a message that can be trusted? Is that something that's part of the curriculum as we identify all these other social determinants of health? Are you educating on that piece?
Yes. We have incorporated into our curriculum cultural sensitivity. So a large portion of our training, both in the classroom and in the clinical setting, incorporates cultural training. HBCUs have been noted for being a trusted source of information. So we're at an advantage because of that, and even more so now. One of the priorities of the task force that's co-led by Dr. Rebecca Gee has recommended, and we're going to push legislation, is that there will be a required cultural training, racial sensitivity curriculum. It'll be a mandate that medical schools, all schools that prepare healthcare providers, have this threaded throughout their curriculum so that it's not a hit or miss. And so that's how we're able, to reach that population with cultural sensitivity messaging.
Right. And Dr. Malone, if I may ask, you talked about some of the students you've worked with. Are many of the students afraid or embarrassed to admit they don't have access to resources? Are they candid with you, or do you find that the communication is built over time, or do the students show up and admit that they don't have access to water, I don't have transportation? If I'm making sense, like, do you feel that you're getting good communication from the students because you're there on site in their school?
I can hear some of the question, but it's kind of muffled. Can you repeat again, please?
Let me see if this is better. Are you able to hear me better?
Yes.
A little bit. Working in the school-based clinic at Northside High, do you find that the students are afraid or hesitant to admit their lack of resources? Or you being on site, does that break down a lot of barriers to getting appropriate health care treatment?
I think it's both. School-based health centers are known to be a good resource for students simply because, number one, they're located on the school campus. And then also it's a place where they gain more trust they have someone that they can speak to. And so it becomes a place where they can open up and share whatever it is that, whatever problems that they have. So once you gain that student's trust just by seeing them a little bit more often and they see you on the school campus, then they're able to open up. For the most part, I have no problem with them sharing information with me. Some things you don't want to know, but also,
TMI.
so I think they feel very comfortable with letting us know exactly what their problems are and issues are.
Mm-hmm.
And, of course, the lack of health care.
Right. Dr. Bosch, where Dr. Malone is, 70501, is a zip code that y'all were speaking of, all of you. It's identified as a higher risk area because there's a higher level of poverty. People may not have dependable transportation, jobs. Once you've identified these areas, though, how do you translate the knowledge to the boots on the ground, getting the resources there to help that population? Is that too big of a question?
To work with partners. Are you able to hear me okay?
We can hear you now.
Okay, thank you. So I wanted to emphasize that the data would help match need with supply. So often our partners, health systems and payers, have existing partnerships with community benefit organizations that are delivering benefits around health literacy or transportation support or other benefits around access to care. And so we are able to support the allocation of those resources on that final common mile, if you will, directly to the patient group. I want you to know, though, it's so much depends on the community. So with advanced analytics, you can learn more about the food insecurity in a given area and understand what might be the language spoken in that area, what might be the food sensitivities in that area, understanding the concurrent social risks more than just food, a well-rounded solution that supports the entire group rather than just one patient in one provider's office at one hunger. So the short answer is we have to work through partners that know the communities and help really extend that knowledge that they have already.
This is what Beacon Community Connections is all about. Holly, I'm going to turn this over to you, but this is what you've been working on to get access to care to those most in need. I know you've got some questions.
Yeah, so, I mean, really, and Ryan and I have talked, before about this. One of the great things about the 21st century is big data, and socially determined, and there's some other companies out there that are doing something similar that are able to take this data, and I'm not a technologist, so I'm always in awe of people that can do this, and really turn it into actionable information for a variety of people, healthcare providers, that could be hospitals, that could be insurance companies, as well as government agencies. So, Tina that we talked to earlier, and then Dr. Brown being on the health, chairing the Health Equity Task Force, and then it comes down to even people that kind of, I see Beacon is really bridging the gap between healthcare and social services, because what we know about, and Ryan earlier said, I'm talking about health, not healthcare, is that 80% of a person's health comes from where they live, work, and play. It comes from these social determinants of health. Only 20% of your health is really derived from health care. Not that health care is not important, because I'm a big believer in health care, but it's just when you're looking at a holistic view of a person, you have to take all those things into consideration. And, healthcare providers are stretched, all the time. And Iris was talking about, Dr. Brown was talking about it too, the medical mistrust. The patients come to Iris after they leave the doctor's office. I didn't understand them, and maybe the doctor didn't take time or didn't have the time to take to really sit and work through them so they have understanding. So I know I kind of rambled a little bit. I hope I answered, the question. But I guess the question that I have for each of the panelists really is, each of y'all kind of touched on communications and medical mistrust, and I'm wondering how each of y'all would seek to improve patient and provider trust and communications. What do you see as some of the solutions for that?
I can take the first crack at that. I think we as providers need to be better listeners. Often the message is first about relationship and trust. And if we can be better listeners to what's going on in our patients' lives, then I think we'll have more opportunity to help support that patient's choices. I'm humbled as a doctor to know that despite thinking I'm a good doctor and knowing I'm board certified, that 50% of the prescriptions that I prescribe, my patients never take, ever. Like I said, I'm humbled. I think I'm better than that. I want you to know, but I have to say that is what is out there. So I would start with being better listeners.
I would echo that. I train nurse practitioner students, and the first thing that I tell them is to build a trusting relationship with your patient. You can learn what's going on with your patient. 80% you can arrive at a diagnosis just by listening. What my patients often tell me is that the doctors, they're feeling that they're talked at instead of listened to. And so I think as healthcare providers, we have to do a better job of listening. And Dr. Malone shared that, some of the patients, we did a small study where we had two nurse practitioners go in the room, one sat and one stood and talked to the patient. They were in there the same length of time, they delivered the same amount of same amount of message. When we surveyed the patient afterwards to ask who got the better care, hands down, they said it was the provider who sat, looked eye to eye and listened to them. They both delivered the same message, but it was the delivery, the posturing, and that sent the message that I hear you, I'm listening to you.
And I didn't hear the full question, but I can understand through the conversation that we're talking about how we can be better providers. And so what Ryan had said was true, that I've had patients to actually tell me who had gone to the ER and said, I got a prescription for some medication, but I tore it up and I threw it in the parking lot, So because they were coming back to us at another clinic that we have for uninsured and homeless. And we were wondering why are they coming back? And it's kind of like they didn't listen to me. They didn't hear what I had to say. And I'm still having this problem. And that's all they did was just shove me a prescription that I can't afford. And so I just tore it up because I knew I couldn't do anything with it. So we had to listen to what their issues and their problems were and see what's the best way we can help to resolve that particular problem. Some things was very simple. Didn't take a whole lot to be able to resolve, And so again, I was somewhat surprised that some of the patients were not, I guess, listened to as well as they should have, and so that they did not receive the care that they should have.
You want to roll into sand? Huh? What's that? Okay. Say it again. Okay. Yeah. Is there anything that we didn't cover that you wanted to, like a passing thought that you?
And at some of the,
Can you all hear me? You can hear Ryan? Is there
Yes.
any parting thought you thought we would touch on that we didn't discuss? Is there anything we left out that you'd like the audience to know before we conclude our session?
I have one thing. I think it's important for us all to think about the distribution and the support of the vaccine as we approach 2021, knowing that it is disproportionate in the community that COVID risk affects. And we need to be extremely thoughtful at scale in our states and in our communities, getting vaccine to where it's needed most.
Thank you.
I would echo that as we move forward with, vaccines, to make sure that we are getting trustworthy messaging out, we're dispelling myths, and that the vaccine as a priority goes to the vulnerable populations first who need it the most.
right, and as Dr. Brown said, dispelling the myths, because within the last, few weeks, in fact, my COVID testing, and then we also had voter registration, that kind of stuff. And so as we go out into the communities and try to get people to do more testing, I had to, here at the school, that's something that I can provide to the students, but I had to get, of course, parental consent. And one of the things that as they were looking at, I was explaining to them about COVID testing, and we can also, as a school-based health center, provide immunizations and flu vaccine because of the upcoming flu season that's coming up. And the first thing that they said was, I don't mind signing for that, for the immunization, but I don't want that that COVID stuff. But they thought it was they thought it was a vaccine. And so they think that the vaccine is out versus just ongoing testing. I said, we don't have a vaccine at this time. I said, but so what you're signing for is you're giving me permission to do COVID testing. But there's some misunderstanding that I guess they're thinking that there are vaccines, and a lot of them are refusing to have a vaccine for COVID whenever it comes out. And they are also leery about having the flu vaccine as well. Because if mama or grandmother didn't take it, I'm not going to take it. Or if grandma had a reaction to it, then I might have a reaction to it. So I think it's going to be a lot of education and also awareness of how it can help that person going forward.
Right. I want to thank you all for sharing your expertise with us, Dr. Iris Malone, Dr. Sandra Brown, and Dr. Ryan Bosch. You're really the boots on the ground in different ways that mirror each other. And I feel like I learned so much today from your thoughts. Thank you so much for joining us. Will you please thank our panelists?
Thank you.
Thank you so much. Best wishes as we move forward. We're ready for San? Yeah. I think we'll just stay here instead of taking a break. And our last speaker.
Yeah, we're almost to the end of the morning. It's been a lot of preparation, but the morning has flown by. But I feel like I've learned just so much.
Well, Holly, at the beginning when I started speaking, I was mentioning that this whole conference was really going to be about the social determinants of health. That's something that I wasn't familiar with, I guess, just a year or two ago, and this is really what you focus on. But each of the panel members have delivered a different piece of this puzzle. Mm-hmm. But there's still so many people we're talking about that they don't have access to care and they don't even know where to begin. Mm-hmm.
Yes, and so, the original summit that we planned for 2020 was going to be around social determinants of health, but don't worry, we still have all that planning material, and we're going to come back in 2021 and really do a deep dive into social determinants of health. And I think, you can't, when bad things happen, a lot of people, we try to find the good in things. And so one of the good things that's come about is that I think that there is a renewed interest in health inequities, health disparities, social determinants of health. And I'm hoping that what we're learning as we move through this pandemic about these health inequities, we can apply that to just general health and well-being as we move forward, because it is something that we need. As a community, we need everyone to be healthy. We need everyone to have a sense of wellness.
Right.
And so I think we're ready for
Sian?
our final speaker of the summit.
Yeah. And this is always a pleasure. Hi, Sian. This is always a pleasure getting to hear from Sian Robinson, who brings his heart, his intellect to the table. And he's going to be talking today about future trends and a call to action. Sian Robinson is Lafayette General Health Executive Director of Innovation, Research, and Real Estate Investment Fund, the Opportunity Zone Fund, and Research Department. And he has also been a key advisor for Beacon Community Connections. So, Sian, thank you for joining us.
Hey, good afternoon, everybody. Great to be here and appreciate the opportunity. I've been listening in all day long, and I think if you're not careful, you can walk away pretty despondent. I thought it was funny that Senator Mills wanted to offer us all Prozacs. And so, but in my mind, the future of healthcare has never been as bright as it is today. And I'm truly immensely hopeful for what could be the silver lining to this pandemic and everything we're going through. And I really want to touch on, briefly on 5 different areas that I think offer the most promise and are the future of what we're going to be doing as healthcare professionals. So the first is technology. The amount of money and effort that's being poured into, in the past, electronic health records and other aspects are now coming to fruition. And with the COVID pandemic, we saw the loosening of telemedicine rules and the payment models associated with it. And I truly believe that cat is out of the bag, cow's out of the barn, whatever you want to say. And while we still have to have the economic conversation around it, telemedicine is the wave of the future. It is the way that a bunch of healthcare, be it primary, chronic care management, is going to be delivered in the future. I think hospitals are going to have to rethink their delivery methodology. When you think about it, hospitals are really expensive, highly specific, highly technical real estate. But more and more, the technology that's in place is we can deliver hospital care in the home. And you're starting to see those programs roll out throughout the United States, and the payment models are there. The same thing with doctor offices. It's going to be a real rethinking of the delivery methodology of how we provide and provision healthcare. The underlying piece of all of this is data. The immense amount of data that healthcare providers collect on each of us only rivals what I would say social media is doing right now. And I don't know if you all have been following the use of data, healthcare data, individual healthcare data, but most recently, Ascension, Mayo, and Google were in the news for not such a great way of using individual personal healthcare data. And that was having to do with the marrying of that data in ways that could, again, if you're familiar with social media and the way it's being used, that type of data usage. But I do believe, and what we're seeing across the United States, are health systems that are implementing data governance and data stewardship models that will allow those healthcare systems to use de-identified data, and as Holly was calling it, big data, to better provision and provide healthcare, to pre-identify folks who may be heading towards diabetes or congestive heart failure or chronic kidney disease. And all of these, between the technology, telemedicine, data, are going to enable new delivery models. I think the second piece are payment models. I've talked about telemedicine, but traditionally we have in healthcare been operating in a FFS model, or a fee for service model. And that meant I went to the doctor's office, the doctor provided me some care, I went home, man, I'm not quite feeling great. I go back to the doctor's office, I get more care, I go home, oh Lord, I'm still not feeling good. Okay, I got to go back. Well, in the past, the doctor got paid. She got paid every single time that click-through happened. But now, through leadership at the federal level, leadership with private payers, we're starting to see the value-based purchasing model roll out. And we've been operating in that model for probably a good 10 years, but really within the last 3 to 5 heavily. And what that means is the doctor gets paid, or the hospital gets paid once, and you get paid for the coverage of that care. And if that person comes back in 30, 60, or 90 days, 30 days you may not get paid, 60 you'll get a little bit, and 90 you get a little bit more. But this value-based purchasing model is really going to be rolling out. And so what does that mean? What it's trying to do is drive for the payment for not taking care of the episode, but taking care of the human prior to the episode, and really working on chronic care management, wellness management, and getting that in place. And so there's organizations called accountable care organizations that are being formed that are paying physicians who do that, right? And so you get a click, a bonus, whatever you want to call it, to make sure that that person, if they're diabetic, they're being managed well. If they have high blood pressure, they're being managed well. If they have some type of COPD, they're being managed well. You know, you're going to see other these types of payment models continue to roll out, but it's all driving towards the declination of the cost of care. Because if we could take care of a person at the front end, we can mitigate what happens on the back end and truly provide the required care. Loved the prior session by Dr. Bosch, Malone, and Brown regarding social determinants. Social determinants is a passion of mine. Very proud to have worked with Holly to help form Beacon and be part of that journey. It's a passion for me because it's personal. I saw it with my grandmother, you know, in rural Pennsylvania, who you know, was on social assistance programs. You know, her Social Security check was what she lived by, and she sometimes had to determine, am I going to pay for medicine or am I going to pay for food? She never had a driver's license, so how is she going to get to her doctor's office? And I'll tell you, she'd rather go to the hairdresser than go to the doctor's office, and she'd pay to have somebody drive her to the hairdresser first. And so I would see all of this happening and really realized that when she passed from her 5th heart attack, that truly that could have been prevented, and that she could have lived well. She was 83 when she passed, but well into her late 80s, early 90s. And so with social determinants, it's risk stratification, as Dr. Bosch talked about. How do we take this data and make sure we understand what's going on in these individual communities? It's the strategy to understand it and then to develop the delivery models. It's the mitigation of all that. And that all relates to population health and public health. But the phrase I use is ideation without implementation is hallucination, right? If we understand all of this and we still aren't filling in the gaps by creating the delivery networks to do so, shame on us. And, you know, working with Dr. Bosch and working with Holly and working in Lafayette General, you can clearly see in our urban poor areas and our rural communities that there is a lack of a service delivery network. And we really need to figure out not only how to curate the existing assets, but when there's a hole or there's a gap, we need to fill it. And then if there is truly another silver lining to COVID, it is the focus of racial, social, and geographical inequities that have come to light. And I can't remember if it was Dr. Malone or Dr. Brown who said that this is not a destination, it's a journey that we need to continue on, and we need to continue to address in every way, shape, or form we possibly can, because we can't have this, and we can't have this continue or happen again. To move into a little bit something else, non-traditional players are starting to enter into the marketplace. Why? Well, according to CMS, the size of the healthcare marketplace in the United States is $4 trillion, again, trillion dollars, which is 18% of our GDP. And these non-traditional players have been sitting back and watching us traditional players deliver. And they've been thinking to themselves, we probably can do this better. And so CVS, okay, pharmaceutical, pharmacy, you go, it's also grocery store. They bought Aetna, an insurance company. And now CVS, Aetna have essentially announced that they want to be the primary care providers for the United States. You've got Walmart, who's formed Walmart Health, who has locations in every community across the United States, rural and urban. And they've said, we also want to be in that space. And I wouldn't be surprised if within the next few years you see, or months maybe, you see Walmart announce a CVS Aetna grab, right? So Walmart also buys a payer. And what does that look like? You're seeing Google Health. You're seeing Apple Health. You're seeing Amazon, JP Morgan, Berkshire Hathaway form Haven, right? And those are just the big players. And you can see a little commonality in the tech theme. But there are also thousands of others that are coming into the marketplace to disrupt. And so I'm hopeful for that. I'm glad that's happening. That is making traditional healthcare delivery rethink how it handles itself and manages itself and offers care. And I know I'm very proud of the work we've done at Lafayette General with telemedicine, with care to the home, everything we're doing under Mike Dozier, our Senior Vice President and CIO's purview, under Dr. Logue. You gotta love Dr. Logue. She has been phenomenal as both our Chief Medical Informatics Officer before she became our Chief Medical Officer, and she's doing a phenomenal job. But with leadership like that, the future's bright for traditional healthcare. And I'm going to say that if there are other players out there that don't follow that model or don't move into the how do you create the unified regional health system like we're about to do with the auctioneer, you're going to see a shaking out of traditional healthcare. And if you know anything, you follow Becker's, and Becker's follows healthcare trends and hospital trends, and you're seeing a lot of these mergers and or closings because of this external market, this external players entering the marketplace. But I think what makes me most hopeful, and then I'll stop, and then you'll do a little maybe Q&A, or you ask me some questions. What makes me most proud and most hopeful are the people. I truly think healthcare attracts some of the most passionate, mission-driven, best and brightest folks that the world, America, has to offer. And it's because of these folks and their willingness to roll up their sleeves and do the hard work that I truly believe. And you've seen them today. And when I say, I talk, Dr. Burnell, Chuck Burnell, Dr. Logue, you're talking about Fred Mills, Dr. Stefanski. I mean, all these individuals, clinical, non-clinical alike, have all entered the healthcare space. I truly believe because of these folks, the future is bright. So with that, I'm going to stop.
Thank you so much, San. Holly, do you have questions first that you'd like to ask?
Well, I have a comment that I'd like for Cian to kind of comment on. So as I was listening to all the sessions today, one of the things that really struck me, and I talked about this when we were waiting for Senator Cassidy, was the first session. It was really, they talked about communication and the different ways that they needed to be communicating for COVID. And then, even really Tina and, or Dr. Stefanski and Senator Mills, they also touched on that because when there's a problem, who are you going to call? So they call Senator Mills, evidently. So, which, he's probably not a bad person to call. Or they call the Office of Public Health. And so, they're not calling until there's a problem. And then in the last session we had, we really talked a lot about medical mistrust and how it really, I think Iris really hit it when it really starts with some kind of communication inequalities. And so, as we're looking at the future of healthcare and what I particularly as we get a handle on COVID and we hopefully move past this pandemic, but we take these lessons learned, Cian. How do you feel healthcare, either technology, data, all those 5 things that you were talking about, how can those things really help healthcare get better at communicating?
So Holly, we always in healthcare talk about the right care to the right person at the right time, right? We have to take that another step forward, which is the right information / message to the right person at the right time. And then in the platform and methodology that they are most comfortable in receiving it. And so technology is a great way to do that. But at the end of the day, it's about one person taking care of another person. And I love the conclusion of the social determinants section with Doctors Bosch, Malone, and Brown, which they talked about they needed to be better listeners and communicators, because at the end of the day, it's that relationship and that trust that's built. But I do believe that technology has its play and its space in order for us to get the information and the message across. And one of the things that we did work on during the pandemic with our partner Cox was creating a video on demand channel that curated information about COVID and about how to receive care. And that's extremely important because, as both I heard Dr. Logue and Dr. Brunel talk about, they became the source of true information, right? Because with social media, with the platforms that are out there, there is so much gobbledygook floating around out there that isn't right information. Like, don't take Clorox, as Senator Mills was talking about. It's that type of frustration, honestly, that we feel as part of healthcare systems in us having to mitigate. And so again, curation of information, the right message to the right person at the right time, and creating that personal relationship so that we understand our patients.
You have anything?
I mean, did you have, I can, Cian and I can talk all day about stuff, but Jan, did you have any?
I just
anything?
had one thought, Cian, and it's so good to see you. I miss you guys. I know that Hamper has partnered with Lafayette General to look at delivery of prescription meds. You oversee the Innovation and Research Fund. What are some things you're hoping to see? Do you have like a pie in the sky dream for a new innovation that will bring home some of these ideas? I know that Dr. Bosch is doing a great job, but is there something that's on the horizon, or is this just more of a personal communication that we need to be looking at?
Oh, wow. So great question. I don't think there's a magic bullet or a giant piece of technology that's going to land out of the sky and suddenly bring it all together, right? So if I had to think about it, it truly is, how do we make sure that all patients feel that they're one-to-one with their provider, not one-to-many, right? And how do we make sure that we get into that really understanding how we develop that personalized care model for that person? Because each and every one of us are different, right? But yet we all take the same drugs. We all get the same care model, right? I truly think that we will move more and more towards that personalization of medicine and the delivery of it. It will involve the human being relationship. It will involve the information that we're collecting, and it will involve technology to help that. To talk about Hamper for a second, I mean, really and truly, that is us. We needed to solve a marketplace pressure, which was we opened up our own retail pharmacy as Lafayette General. And, and so now we're competing with CVS, Walmart, neighborhood pharmacies. But we needed to get the medicine to the folks in their hands. And I don't know about you all, but when I have a telemedicine visit, I'm not feeling great. I'm having a visit for a reason. And so we need to get the medicine to the folks. And I really don't want to go drive to the pharmacy to go pick it up wherever they call it in. And so if I can have that script delivered to my house and I don't have to go outside, that's great. But that also makes a lot of sense for pop health management, because what that means is if that person does have the flu or does have COVID or other, even a summer cold that, Tim had, Holly, right? You don't want that person out and about and, spreading whatever they have around. And so being able to make sure that person gets the right care at the right time in the right place. So that's why we worked with Hamper to help them pivot into the space to provide that last mile delivery service. But there's another piece, and it came back to what Dr. Bosch, Malone, and Brown kept talking about was 50% of their patients that are prescribed something don't take it. Being able to deliver that to them, that they get prescribed, and tell them, you don't have to go to the pharmacy. We're just going to bring it to your house and deliver it to you, and then have the care team that follows up afterwards. That's pretty powerful stuff, because that's called medicine adherence. And I'll tell you what, our ERs are full of folks that are prescribed medications that don't take them, that come back.
Mm-hmm. Great answer. Thank you so much. I'm going to turn this over to Holly.
I think we probably have time for just like one more question, Cian, and I think it'd be interesting. I think that you have just a fascinating job. I could never do it, but it always, I love hearing about it. And so I think maybe some of the other people would really like to know kind of a big aspect of your job. From my understanding is that you go out and find solutions. Someone in the healthcare system comes to you with a problem and you go out and find the solutions. Could you want to just spend maybe a couple of minutes like walking through how you do that? And you could use the Hamper as a example, or if you have another better one, that would be great too.
Sure, Holly. So what we do is we work with our internal stakeholders at Lafayette General, and Auctioner does the same. You identify a gap or a need from the senior executives and frontline staff, right? People delivering healthcare. And they say, hey, I wish I had, or I really could need this. And sometimes you can fix that internally, but many times it just doesn't exist. And so you go out into the marketplace and you do an external market scan to see what companies are out there and who's providing what. And many times it has to do with very small companies that are trying to get themselves up and running. And so we then go identify those companies and we begin to work with them. Work with them to perfect business plans, products, services, and provide subject matter expertise to help them move them in that direction. And sometimes that culminates in an investment from the Healthcare Innovation Fund, where we become an equity partner. And what's brilliant about the Healthcare Innovation Fund, it isn't just us at LGH, it's also Auctioner, it's the Myers Family Foundation, it's the William C. Schumacher Family Foundation. And for those of you who don't know the Myers Family Foundation, the Myers family founded LHC Group, right? Schumacher, Dr. Schu's Family Foundation. And we also have Acadian Company. So we have a majority of the healthcare players in the marketplace, our marketplace, at least Louisiana, if not across the country, who are also looking at this. And so we can then drive those solutions through the rubric of, we will only invest in you if you're going to solve a problem for us and we can use you. So we go from being not only owners, but also clients as well. The joke I use is, to get to one of those, I got to see 10 of them. And the other joke is, there are lots of entrepreneurs, but there are about 10 times as many entrepreneurs that are out there as well. And so I spend a lot of time working with the folks that fall into the bucket of bless your heart. And then we move them over to great organizations, LEDC, Opportunity Machine, the SBA. There's a lot of great public sources out there that they can help these companies perfect themselves to either move them out or bring them up and bring them back. But it's a lot of fun working with just wicked bright people who are trying to figure this stuff out. It's just a ton of fun.